So, osteoporosis, what a doctor should know. So, when I reflect on my as a trainee doctor, I knew very little about osteoporosis. So, when I came across this topic, I always had a very eerie feeling. But now I'm a consultant. I have learned a lot about osteoporosis. So now when I see patients, I'm even more terrified because this is a gray area, lot of controversies, and then it is rapidly evolving. So my duty is to make this complex field a bit more easier for you all to understand so that you will have some kind of grip on the patients whom you. So this is Inga Ludengard. So she's a Swedish lady. In 1959, you can see how her back is. And in 1989, still she has a straight back after almost 40 years. But within the next 7 years, you can see the rapid transformation in her whole shape. So she has developed this kyphosis due to multiple vertebral fractures. So this is the dreaded disease called osteoporosis. But this disease could be prevented, it could be diagnosed in time, and it could be treated effectively. So that's why we are here. So the outline of my presentation will be as follows. First, we'll see what osteoporosis is and how do we diagnose this condition and when do we treat these patients and how do we treat these patients. So these are the 4 questions that I'm trying to answer within the next half an hour. Sonali has already explained the gravity of this condition, and even in Sri Lanka, it's quite a common issue. So I'm not going to focus too much on that. So then this is the definition of osteoporosis. So from my school days, I hated definitions, right? So it's very difficult to memorize. It doesn't mean much also. So what I gather from this definition, WHO definition is osteoporosis is a condition where you have low bone mass and low bone quality. Both put together, there is increased risk of fracture. Okay, so if you understand that, that's good enough. So the way I look at bone, because Dr. Kapila Ranasinghe being an orthopedic surgeon, he will look at bone in a more objective way. But as a naive endocrinologist, for me, the bones look like a concrete pillar. So in a concrete pillar, I see 2 components. One is the iron rods, the metal rods that are there. That is the connective tissue of the bone. And then you have concrete, okay, with cement and all those things. So that is the mineralization of these metal rods, the connective. So when you talk about osteoporosis, there are 2 issues that you see there. The metal rods are also damaged, and then the bone mineral, that is the concrete content, is also lost. So then that is how I see osteoporosis. But if you look at osteomalacia, it is a problem with mineralization of bone where the metal, the rods are there. They are intact, but they may get curved sometimes. You get silent fractures and things like that, and green stick fractures, looser zones. But the mineral content is not there. So in osteoporosis, the metal rods are also damaged, concrete is also damaged, it's lost. But in osteomalacia, the rods are there, but the concrete is lost. Okay. So then here you see a bone where there is osteoporosis. So then the bone mineral content is also reduced, and then the architecture is also compromised there. Then osteoporosis, it affects the entire skeleton, but it's a systemic disease, but the fractures occur at vulnerable points. Okay. Just because someone gets fracture in the forearm, you cannot think he has osteoporosis in the forearm, but rest of the bones are strong. No. And fracture in one area, it predicts the risk of fracture in other areas also because it's a systemic disease. There could be one pointer. So the common size are spine, hip, and wrist. So why are we so worried about fractures? Because Kapila will fix them nicely. But if you look at the aftermath of it, within 1 year, 20% of these patients who develop hip fracture will die. Not because Kapila made a mistake, okay, because that's the way it works. And then 30% will have permanent disability. and 40% will be unable to walk independently, and 80% will have at least one activity of daily living will be impaired. So then it causes considerable morbidity and mortality. So we'll look at how this bone mass is formed. So when we are born, we come with low bone mass, and gradually we accrue that. And around 30 years, 30 to 40 now they say, we achieve our peak bone mass. So males, they have a higher peak bone mass than females. And after that, you can see the bone mass gradually coming down. But in female, you can see a dent around menopause. So that is where you get this postmenopausal bone loss, a rapid one, and it continues from there onwards. So then this osteoporosis all don't lose at the same rate. Some people, they have a higher chance of getting osteoporosis. So one is age. That's a definite association. As we grow older, the chance of getting osteoporosis is higher. And then those who start with a low bone mass will be losing more, and they also will have osteoporosis. Caucasians and Asians, and previous fragility fracture. If someone develops a fracture, within the next 5 years, there's 30% chance there's going to be another fracture. So all those patients, you have to take them very seriously. And then positive family history and low body mass index. So when I say low BMI, I'm talking about very thin people, BMI less than 19. Otherwise, all of you will want to increase your body mass index from today onwards. So then lifestyle factors such as diet, smoking, and alcohol, and early menopause or early surgical menopause. And then, as I told you before, if you have one fracture, those patients, you have to be more careful because they have a very high chance of developing another fracture. But when it comes to myocardial infarction, even when you're in your sleep, you will get a myocardial infarction. But when it comes to fractures, you need two things. One is weak bones. Second is there should be an impact. So there should be a fall. But spontaneous fractures are there, but it's very rare. So then it's not only weak bones, you have to focus on the chances of a person having a fall also, right? You should not ignore that. So in Sri Lanka, in one study, over 4 months, our elderly people, almost half of them have had one fall. So then fall prevention is also part of this. Now, all this time I was talking about primary osteoporosis. That's that age with age, whatever that happens as a natural phenomenon. But now there are other causes which can exacerbate this further. So there could be endocrine causes such as hyperparathyroidism, hyperthyroidism, hypogonadism, Cushing syndrome, then nutritional causes, certain drugs, especially steroids, immunosuppressants, and anticonvulsants, and immobilization, because if someone is immobile, very rapidly they lose bone. Okay, so something that you should keep in mind. And then diabetes is also a risk factor of osteoporosis, just as rheumatoid arthritis and certain malignancies. So what are the clinical features of osteoporosis? So mostly it's a silent disease. So if they have hip fractures, anybody can diagnose it. And vertebral fractures, 60% of them are silent. So you can see a person getting kyphosis, height may become shorter, but the patient may be asymptomatic. And Colles fracture is one of the earliest fractures that people get in the course of osteoporosis. And then the changes in body shape due to height loss, kyphosis, protruding abdomen, increased pulmonary capacity, and reflux esophagitis. So these are in severe osteoporosis. If the thoracic shape is changed, these are things that you will encounter. But something I would like to highlight is don't go with the idea back pain is equal to osteoporosis. So here what happens if someone has back pain, we ask for a DEXA scan and then that shows osteoporosis, you send to a doctor, an orthopedic surgeon or an endocrinologist to treat. And the patient comes with the idea, if I take treatment, osteoporosis causes my back pain. If someone treats my osteoporosis, my back pain will vanish. That's completely false. So then there was no indication there to do a DEXA scan. Now, history, when you take the history in a female, you have to look at the menstrual history because of hypogonadism. In male, features of hypogonadism should be looked into. And then look at the chances of a person falling. Okay, so don't forget that. And then features of endocrinopathies and previous fragility fractures. And in examination, generally it's going to be unremarkable. except for some obvious signs of fracture. So you may get localized spinal tenderness when you examine the spine in some of these patients. Then we'll come to another murky area, how to diagnose osteoporosis. So here, rather than calling how to diagnose osteoporosis, actually the terminology, how do we diagnose increased risk of fractures? So we look like that, look at it that way. So if someone has a fragility fracture, already we know that there's increased risk of fractures. And we can measure the bone mineral density, that concrete in that pillar, and then that also will help us. And then just like this cardiovascular risk scores that we have, for osteoporosis also we have our own scores. So that's called the FRAX score. So these are three tools that we could use. So again, bone mineral density, the amount of concrete in that pillar. So then it's the amount of bone mineral in a certain area of bone, right? So then when we look at bone strength, we said it's the amount of bone mineral and the quality. But measuring bone mineral density alone has shown a linear correlation with fracture risk. And then this correlation is stronger than the correlation between dyslipidemia and myocardial infarction. So although we are measuring only one element of the poor quality bone, still that's a very good tool. So then the machine that we use for that is called a DEXA scanner, dual energy X-ray absorptiometry. It quantifies the bone mineral density. These are non-invasive tests. You don't need any special preparations. And the radiation is only 1/10 of that of a chest X-ray. Okay, so you should not go with the idea it's as bad as CT scan or something like that. No. So here what we do is we capture a particular area and look at the amount of bone mineral that is there. So it's a two-dimensional thing. So although we call it density, it's given in gram per centimeter square. So this is the DEXA report. So when you see the DEXA report, all of you must be confused. Okay, so now I'll try to explain some of these features. So here we look at the region L1, L2, L3, the area that we have captured here. So then you measure the area and you measure the bone mineral content in the area and you calculate the bone mineral density in a two-dimensional image. It comes as gram per centimeter square. So this bone mineral density up to this point, I like it a lot because it's very useful. But beyond that, you have this T-score and Z-score. So during my student days, I hated it. Now I hate it because it belongs to the Americans and it doesn't belong to us. Okay, not because I don't know it. I'll come to that now. So then bone mineral density, T-score and Z-score. So now what is T-score? In T-score, what we look at is how much bone mineral that we have lost. So then all of us at 30 or 40 years, if we get our bone mineral density done, then straight away we can deduct and say this is how much we have lost. But it doesn't happen. So then you have a community value of peak bone mass and you compare with that and see how much you have lost. Okay, so that is T-score. So when you lose something, how much you have deviated from that mean. So then you have to give it in standard deviation. There's no other way in which you can give it. So it's standard deviation. So then this lady, this was a bone mineral density when she was 30. Now she has moved to this range. So then here we are seeing how much bone mineral density that she has lost. Okay. So then you quantify that -1 standard deviation. After that, you call it normal. -1 to -2.5, you say it is osteopenia. And -2.5 and below, you call it osteoporosis. That's what's given here. Understand? Right. But this peak bone mass, that reference population is Caucasian females. It's from the American database. So then the reference population is not our Sumanavati and Siryavati. Okay. So then their peak bone mass is certainly not equal to the Caucasian peak bone mass. That means our peak bone mass is not equal to that. So then the reference range is faulty for us. Then this T-score -2.5, it's not a magical figure. It's an arbitrary figure that they have derived based on medical criteria and economic criteria. So if it's only medical, it's a different story. But economic, it's based on the number of DEXA machines that are available and then the insurance reimbursement schemes. So then that minus 2.5 belongs to the Americans. It belongs to us. Okay. So then here what happens is this T-score, you should know the T-score, you should know the cutoff, but you should know that there are caveats. Okay. And then this T-score can be used only after you have lost your peak bone mass. Okay, reach your peak bone mass in the losing stage. But the data is stronger only for postmenopausal women and men over 50 years. So that's why T-score can be applied only for them. So what about the others, those who have T-score less than that? Those who are less than 50 years. So now here you can see this young gentleman who is less than 50 years. So if you were to compare his bone mineral density, you can use T-score. So you have to compare with his peers, people around the same age and same gender. Okay. And you have to see how much he has deviated from other men of the same age. So if it is less than minus 2, because anything that we talk about, if we say TSH is from 0.4 to 4, we are talking about minus 2SD to plus 2SD. That's the confidence interval to catch 95%. So then if it is there, then you are not worried. You say his BMD is normal. But if he goes beyond that, you know he has overshot his reference range. Okay, so then you can't use the word osteopenia and osteoporosis here because that is only meant for T-scores. So here you will say low BMD for chronological age or below the expected range for age. So then I spent a little bit more time here in order to make you understand T-scores and Z-scores so that you will understand how to interpret the DEXAs. Then the third tool is FRAX, because now we know DEXA, that interpret BMD is good, but interpretation is American, according to American standards. Now we look at FRAX scores. This is to calculate the 10-year risk of developing a hip fracture or a major osteoporotic fracture. So it takes into account clinical risk factors and the femoral neck BMD, but you can do without the BMD also. So this is the tool that it's an online tool. So here you can see it calculates the fracture risk. So according to the American, and for Sri Lanka also, you have our own data thanks to Professor Lekambasam, who has done a lot of research. So you have for Sri Lanka, you don't have to go from any other country close to us, it's Sri Lanka. Then Professor Lekambasam, so 20% for major osteoporotic fractures and 3% for hip fracture is the international cutoff, the American cutoff. But Professor Lekambasam has done a study and he has given our own cutoff for FRAX. So that is 9% and 3%. Okay? So you have to keep that in mind. And then there are some investigations that you have to do to rule out some of these things. So then calcium, phosphate, alkaline phosphatase, vitamin D, full blood count ESR to exclude multiple myeloma and renal impairment and TSH. So these are to make sure some of the common secondary causes are not missed. Okay. Then when to treat. So just because someone diagnoses osteoporosis, that does not mean you are going to treat, because diagnosis is based on American standards. So therefore, diagnostic threshold and treatment thresholds are different. So when you treat osteoporosis, you have two components: universal recommendation, that is all postmenopausal women, in order to prevent fractures, you have to follow certain things. And then pharmacological treatment, that is for people who have osteoporosis and there is a very high risk of osteoporotic fractures. So then pharmacological treatment is meant for people with osteoporotic fractures. T-score less than minus 2.5. Again, it's American standard. Osteopenia, if it is minus 1 to minus 2.5, you will go for the FRAX score. And if the FRAX score has more than 3% and more than 20%, you will go for that. So that means either a fracture or BMD minus 2.5. If not, you will go for FRAX score. This is the American method of doing that. But that standard is also that cutoffs are wrong, because we have 9% and 3%. And then minus 2.5 also, we are not going to fully adhere to that. So here, according to recommendation, all women over 65 years should be screened with DEXA scans, and then 17 certain countries. So So if we were to apply that method here, we will have a queue here. If you ask why are you waiting, they will say we are waiting for a DEXA scan. So then you can't apply that. So the British, they have an innovative method. They use their own FRAX score. Based on the FRAX score, they will decide whether the patient falls into the red area where you treat. And then whether the patient falls into the green area where you don't have to treat, only encourage lifestyle modification. And the yellow area, you will do the DEXA scan. So then only selected patients will undergo DEXA scan. So we have to have that kind of a method. So very likely one of our expert group is working on that. We'll come up with our guidelines. Then how to treat. So in the interest of time, I will be looking at only some aspects of it. So universal treatment, calcium, vitamin D supplementation is always beneficial, around 1000 to 1200 milligrams of calcium. And then vitamin D, around 1000 units, because vitamin D deficiency is very common in Sri Lanka. Although we have enough sunlight, Western people have sun-seeking behavior. We have sun-fleeing behavior. So I took this photograph while I was traveling in the observation cart. So you can see a foreign couple on the right side. So then the curtain is all open, so they are getting the sunlight. The Sri Lankan couple, they have drawn the curtain so they won't get sunlight. So that's sun-seeking behavior versus sun-fleeing behavior. Then exercise. So there is, Asela will talk about it. You have to prevent falls. And then you have to gain weight, not all of you all, people who are so thick. And then stop smoking. And then pharmacological treatment, the principle is bone has formation and resorption because it's a dynamic structure. Then only all the microfractures could be resolved. And then in osteoporosis, the formation, when you treat, the bone resorption should be brought down and formation should be brought up. Okay. So then these anti-resorptive agents are bisphosphonates, HRT, SERMs, denosumab, and calcitonin. The bone formation agents are teriparatide. There are new drugs also. So now when you look at bisphosphonate, it inhibits osteoclast activity. So bone resorption is inhibited. Then the drugs that we have are alendronate, risedronate, and ibipronate. These are oral drugs. And zoledronic acid is the intravenous drug that we have. But before starting bisphosphonate, always look at the calcium because they can get hypocalcemia with bisphosphonates. And then vitamin D, if possible, you can check it. And then renal function should be checked because if the estimated GFR is less than 35, you are not supposed to give bisphosphonates. And then if they are awaiting any dental procedure, invasive dental procedure, first you have to ask the patient to undergo the dental procedure and then start bisphosphonate, otherwise they might get osteonecrosis of jaw. Then achalasia or esophageal strictures, you should not give oral bisphosphonates. Then you have to take it on an empty stomach because it's the bioavailability is only 10%. And then you have to drink a full glass of water because if it gets stuck in the esophagus, it can cause irritation. So, and then the patient should not lie down for 30 minutes. So some people say you stay still for 30 minutes. No, that's not required. They can stand up, walk about, sit down, do whatever they want to, but they can't go to the reclining position because it will get regurgitated. And then they should not eat or drink for 30 minutes to improve the bioavailability. And then zoledronic acid, we generally give it once a year to improve compliance, and then the absorption issues could be circumvented. And then 5 milligrams is dissolved in 50 ml to 100 ml saline and infused over 15 minutes. If you want, you can infuse over a longer period of time to minimize the side effects. And 4 milligram zoledronic acid is cheaper than 5 milligram. That is as effective as 5 milligrams. So we can easily use that. And then common side effects are upper GI side effects and musculoskeletal pain. And then osteonecrosis of jaw is very rare. So a dental checkup in those who have poor hygiene is always recommended. And if you continue to treat, they can get adynamic bone disease where they get atypical fractures. So these are at the mid-shaft level. And then denosumab is a new drug that we have, again an anti-resorptive drug. It's a monoclonal antibody. Once in 6 months only you have to inject it. So if you look at the mechanism of action, so these two gentlemen, you will think that they don't see eye to eye. but behind the screen, they are like this. Okay. So then denosumab is just like that. So here what happens is osteoblasts and osteoclasts, we think that they don't see eye to eye because one is involved with bone formation, other one is involved with bone resorption. But osteoblast is secretes a product called rank ligand, which binds to the rank receptor in osteoclast and it stimulates osteoclast. So then this denosumab, it go and blocks the rank ligand so that the osteoblast stimulation of osteoclast does not take place. Okay, so then this is also a very potent drug, but it's safe in renal impairment, but it has been studied down to a creatinine of EGFR of 15, but it's expensive and it's not considered as first-line drug. And if you stop it, there's rapid bone resorption, so you have to have another plan for that. Then HRT is also used, but it's not the best drug for fracture prevention. So, but if someone has postmenopausal symptoms along with osteoporosis, very early stage of menopause, perimenopausal period, you will consider HRT. And then SERMs, they are selective estrogen receptor modulators. They will reduce fractures, but the important thing is if someone has increased risk of breast cancer, then this may be a drug because it's like tamoxifen. Then calcitonin is no longer used as a treatment for osteoporosis, but those who get vertebral fracture causing pain, the intranasal calcitonin can be used to relieve pain. Then teriparatide is a bone formation agent. So it's parathyroid hormone. So parathyroid hormone, which is if it's secreted continuously, like in hyperparathyroidism, it causes osteoporosis. But when you give it as intermittent injections, it stimulates osteoblasts more than osteoclasts. So then it is a treatment for osteoporosis. It's a wonder drug, I would say. But we don't generally continue for more than 24 months because in rat models, it causes osteogenic sarcoma. But I don't think in time to come that if the approval already, they have eased this thing, you can go beyond that. And then how do we select from these drugs? If someone has oral bisphosphonate will be the first line for osteoporosis. Zoledronate you will select if someone has GI symptoms, their pathology or compliance related issues. Because in when I was in Oxford doing my overseas training, they had a protocol because alendronate is much cheaper than zoledronic acid because that's more than 100,000 zoledronic acid. So they say first you have to give alendronate. If there are GI side effects, then you try risedronate. If that fails, then you go for zoledronic acid. But in Sri Lanka, we just pick. But if someone has definite contraindication for this thing or compliance related issues, then you can justify and straight away go for zoledronic acid. Otherwise, when we get something free of charge, we don't know the value of it. We put alendronate and zoledronic acid in the same platform. And then teriparatide, if someone has severe osteoporosis, and if bisphosphonates are contraindicated, or if that person can't tolerate bisphosphonates, or if the person is not responding to bisphosphonates, you can think of teriparatide, but it costs around 30,000 a month. And then denosumab, again, if bisphosphonates cannot be given or the person can't tolerate it, or if there is renal impairment, then you will consider denosumab. HRT is mainly for menopausal symptoms associated with mild osteoporosis in the perimenopausal period. Otherwise, it's not a wonder drug as such. So if someone has breast cancer, then out of all the medications, if the osteoporosis is not very severe, you will select SERMs. And then, but on the other hand, if someone is on aromatase inhibitor for breast cancer, that is going to worsen osteoporosis, then you will select bisphosphonate to treat them. And then calcitonin is only for painful vertebral fractures. So there are some new drugs in the horizon, romosozumab and abaloparatide is an analog of parathyroid hormone. So you can read about them. And then you have to monitor treatment as well. So the only tool that we have to monitor is DEXA scan. Otherwise, you can't make the person fall and see whether the person is getting a fracture. No, that's not practical. And FRAX score also, is it something that we can use to quantify? No, it says yes, no. So then only tool, but BMD is good. Only that derived score, because our A-level marks is good, but compare putting Z score for Candy people higher Z score and Mondragon a lower Z score, that is where the problem is, right? So that's how you have to understand it. So then here we are only comparing BMD, so it's good. So every 1 to 2 years you can measure, but again, that's a topic in itself. And then when you do repeated measurements, you have to use the same machine ideally and same technician, okay, because there could be variability. So then just because it belongs to Hologic brand, another Hologic brand won't work. Ideally, this hospital's Hologic machine and ideally same technician. Failing which another Hologic is okay. But if you do it in a totally different brand, then you can't compare the two. Okay. So then the take-home messages are, my dear friends, osteoporotic fractures cause significant morbidity and mortality, so they have to be prevented. And then the way in which we can diagnose increased risk of fracture is by like a past history of fracture, and then BMD and FRAX scores. And then whatever the T-score and Z-score that we see in the DEXA machine report cannot be straight away extrapolated to our people. So you have to have that in mind. And then when you treat osteoporosis, there are universal recommendations, that is vitamin D, calcium, exercise, the fall prevention, those kind of things. And then there are specific pharmacological treatments. So the bone formation agent is teriparatide. The bone resorption agents are anti-resorptive agents are bisphosphonates, HRT, SERM, denosumab, and calcitonin. When you monitor response to osteoporosis, the only tool that we have is bone mineral density. Again, it has to be the same brand, same machine, and the same technician ideally. Thank you.
But when it's come to this particular exercises for osteoporosis, and everyone like wanted to know, what is there like real indication for osteoporosis? What are the type of exercises and how we are going to implement it into our life? When should we start this one ideally? Or what are things? It's bit of a the area, because nowadays with this new development and introduction of the exercises, especially based on America and other countries where exercise is medicine is the theme, EIM. So I'm going to talk about how this the concept is being implemented, but in a larger scale. But mind you, the before starting, so I would like to highlight few things. One thing is we have like few capsules which is free of charge for us, but we just almost neglected. So what are these free capsules or the free medications that we can actually have in our life? One thing is the exercises. You don't need to do any expenditure for exercises unless you go for a standard gym or very high expenditure gym when you really wanted to do it. The other thing is as correctly mentioned by Dr. Charles, the sunlight, the vitamin D, right? We all, try to, get away from sunlight, and we just miss one of the valuable thing which we already know. And the other one is the nutrition. Anyway, we consume our day-to-day, whatever the diets, but unfortunately, as medical officers or even the people who have some knowledge, but you can think about yourself how efficient or how scientifically you are take your meals, but on what cost that you are doing it. Anyway, so starting up to this topic, so what exercises can do for these particular structures? I'm not talking about the things which is being on your right side corner, but if it is muscle, definitely when you're doing the exercises, there's a increase of mass and strength. And when it comes to the bone cells, osteocytes, osteoblasts, and osteoclasts has different effects. Survival, sensitivity, apoptosis will go down, but the sensitivity and survival will increase definitely. In osteoblast, there's a differentiation in proliferation and mineralization is increased, but apoptosis is reduced. In osteoclast, the formation and differentiation go down. So you can think about within this very clear picture how this can be happen. So these are the ideally the effect of the multifaceted hormone, which we are referring as irisin. So this irisin has a pleiotropic effects. So that means it exerts in multiple diverse biological sites, as shown in this picture. You can see very clearly how the diverse actions of this irisin. The irisin is a hormone which actually generate in your muscles. That's a myokines, and it will be cleavage into a different component, and it goes around and it affects all these the specific sites and all the effects of your body. So specifically, I'm not going to talk about many other things like how it affects on insulin sensitivity and anti-inflammatory, anti-hypertensive, anti-apoptotic effect and antioxidant effects, as well as many other effects. So this is the area where I'm going to highlight and touch within my topic. So as clearly said, so it has a positive effect on osteoblastogenesis as well as osteogenesis, and end of the day, giving rise strong muscles. So when you're doing any physical or exercises or physical stress on your muscles, so the irisin is secreted in a massive amount, and it has in its own effect. And at the end of the day, so you can see the bone mineral density and it's recovered, as well as new bone formation is being triggered out. So when you're applying your correct protocols, exercises at the right time, so the fragile bones can be converted into the healthy bones with other supportive the measures what already spoke and highlighted by my previous speaker. So on top of that, it has its own muscle. So ideally, the irisin hormone is actually identified that it converts the white fat into the brown fat. But that is one of the major thing. As you know, the obesity itself is a huge issue, and it also actually reduce your muscle mass on the other hand, and also it induce the osteoporosis and osteopenia and osteoporosis. So irisin has these all effects: increasing bone mass, bone formation, and bone marrow density, vitamin D levels of the body, and pro-inflammatory cytokine series actions. And on top of that, it has a direct effect of reducing the hip fractures and osteoporotic fractures, any occurrence, and also the bone mineral content increments. So the exercises has its age-specific actions. So in young people, the exercises increase the bone mass density, whereas it it also increases the bone size. That also periosteal apposition. But in elderly adults, or where we are come across with most of the problems, so exercise increase thickness and the resistance of the cortical bones at loaded skeletal sites. But that's the important thing, because we sometimes, because in our body, most of the times we have loading areas and unloading areas of the skeletal system. So specifically, if you are doing the exercises, this is the most vulnerable site to get fractures, and it will increase the cortical bones resistance. And mind you, it lower the loss of endocortical bones and increase the tissue density. So these are direct and observed and already identified causes, effects of exercises. So what are the type of exercises that most effective for all age groups? Because we cannot prescribe, or we cannot look for every type of exercises for all age categories, especially when you are getting older. So we have limitations. We have the all sort of metabolic and as well as aging related problems, and also the functional and strength issues. So you have to really think about these things. So the word weight bearing aerobic activities are very important. What are the non-weight bearing aerobic activities like cycling, swimming, and all these things? It doesn't cause any weight bearing to your body. But whereas when it's come to the walking, stair climbing, jogging, like tennis, volleyball, tai chi, dancing like activities are considered as weight-bearing aerobic exercises. Those things are actually indicated for all age group, irrespective of what is your age. I'll show you few of my slides later, the lifespan, entire lifespan, how we are going to do the exercises from the infants onwards. So the strength and resistance exercises are another important category of exercises which we are talking about every time these days. Now, when you're prescribing exercises, we don't talk about much on aerobics. Of course, we are talking about the weight bearing aerobic exercises, but we concentrate more on strength and resistance exercises. Even in our practical sessions, even when we are recommending our exercise program, this is the first one, and this is the most important thing according to the new criteria. So free weights, the machine assisted weight, and tubing. You can see some of the resistance band, we call it the TheraBands or the resistance band. You don't need to have a gym, just a one resistance band. It's like a total gym. You name it, any muscles of your body, we can do exercises using this particular band, and which is a very important type of exercise which are doing. It's one's called isokinetic exercises. The isometric exercises is where you contract muscle without joint movement, but isokinetic is the exercises which usually you do, even if you go to a gym or whatever, you take dumbbells or anything, you do the same weight, actually the same resistance applied throughout the every angle of the movement, whereas isokinetic, you change the resistance throughout your angle. So you can imagine when we are using this resistance band, when we are applying the pressure, when we are moving the arm with around the joints, so resistance will increase with the increase of the tension of the band. So this is extremely important, and also it's happening all around the world. And using your own body weight, and you should understand that our own body is a machine, right? You have to really use your own body weight to do certain exercises, like kind of a push-ups, even sit-ups, and also some squats, like many exercises. Right. So strength training exercises for osteoporosis, especially special concern populations, the elderly people who are already diagnosed with osteopenia, osteoporosis, are recommended low impact strength training, that is we call the list, for bone health. So we have different individuals who already diagnosed with osteoporosis. Actually, they using this particular strength exercises, they can significantly improve bone density, as I mentioned, as well as their muscle strength. And especially you can actually give these exercises tailor-made way. You don't need to do, stand and do the exercises while sitting on chairs or while sleeping down on your couch. It's like you can really do different type of exercises, especially the people who with other morbidities, as well as when they are aging. So if you really wanted to start exercises at any point of your life, so there are ways and means of doing exercises. That's the important message through this particular slide, which I wanted to address. And balance and flexibility exercises are another important aspect, but I think falls in osteoporosis, will be delivered by my other colleague speaker later. But remember, so balance and flexibility are one of the most important things. Again, we really stress and encourage people to do these exercises before they reach their vulnerable ages. So in our exercise programs, even right from the beginning, even at the childhood exercise programs, we introduce these balance and flexibility exercises in different ways. But on top of that, you have many devices like Bosu ball and balance boards and all these things, but your own body, like single leg standing and wait for about 10 seconds, will be another goal in your life. So if you're trying to balance your body, if you cannot maintain for 10 seconds, remember that's an alarming sign. And it will, there are research done, and it shows that your longevity or lifespan will be shortened by 10 years. If you can't stand for 10 seconds and stay for about, just 10 seconds. So that's a test that you can, think about and see how my lifespan going to be or reduce, right? Yeah. The other important thing in osteoporosis, training with whole body vibration. So this was noted actually significantly, especially in the astronomers in 1950s and 60s, where they reached their, the space level, and when they are like living there for about a couple of months, and when they come back, their bone density has really gone down. So later on, even in their shuttle spaces, they were provided different kind of machines like treadmills machine, and also this stationary cycle and all these things, but still they only developed their muscle strength but not the bone. But there was a significant bone loss, and they were diagnosed as having osteoporosis, actually not the osteopenia. Sometimes there's a significant. So what happened after these findings, NASA and especially the Russian aero specialists, with the help of sports and also with the health care providers, and they developed this kind of a rhythmic oscillation machines, and which we actually inserted into their exercise machines in the space. But it has really now come to the earth level as well. But even in developed settings and some of the developed gyms even in Sri Lanka, we have these rhythmic oscillatory therapy machines, where you do the exercises while on these vibrating plates. So when go for a certain period of time, you can program your time, and entire body is getting vibrating, and its entire body, the muscles and everything get continuous contractions, and it will promote the bone density as well. So these are kind of things that we have to think about in our life. I think, and we are actually trying to get these machines in my units. We have already ordered. We hope that these things will be available for our patients and for you as much as possible. The way to facilitate ourselves. So vibration therapy has a lot of the effects in our body, especially bones and other tissues as well. So achieving peak bone mass through exercise is another challenge. So what are we going to actually really do with this challenge? Is it really a achievable goal? Of course, yes. But have we ever done our peak bone mass or maybe PMD during our childhood? Of course, no. We are not going to do it. But still, you can think about an application of these, especially the physical activity and exercises for younger people, and optimizing the other parameters which we already discussed about the exposure to sunlight, optimizing of their nutrition and all these other measures. But I think that will be the key to prevent as well as achieving the peak bone mass at the early and the correct age. So you can see the second picture there. So that's give us a very important message. If you really go to this aging, the right on the right picture on your right side, and you can see you will reach the peak height in the females and males in an earlier stage, but whereas your peak bone mass will be reached, somewhat later stage. But during that particular gap, so there is a period of less bone mass, because the height to bone mass density, there's a gap. So especially you have to really think about what are you going to do for those kind of things, because the group which we come across most of the times with some fractures common in children or adolescent age. So in UK Chief Medical Officer's physical activity guidelines laid down in 2019 is given this particular guidelines. You can see in infants less than 1 year also recommended some exercises. It's not that, you know, the regular exercises, but they were allowed to do the tummy time, but that's not the sleeping tummy time. 30 minutes per day may be calculated and to stimulate their tactile stimulations as well as their physical activities, the head control and all other physical qualities. Toddlers from 1 to 2 years, you can see they need to have 180 minutes, 3 hours, variety of activities of, you know, different intensity, including outdoor and indoor both. Especially the preschool children age 3 to 4 years also the same. But you can think about whether your child is actually doing 3 hours physical activity per day. So it's quite inadequate, and you know by yourself how inactive they are. So additionally, children and adolescents 5 to 7 years, more than 60 minutes per day, strengthening and muscle bone exercises at least 3 times per week. So that's another important message, because most of our children, even ourselves, they don't start strengthening exercises and they are scared. They think when you are doing strengthening exercises, gym-based exercises, it will hamper your height or it will damage your cartilage. There's no scientific evidence, no data that it will do so. And there are so many children actually who do supervised strengthening exercises without harming and without damaging their any joint or any cartilages or any part of their the bodies, and they do grow and they achieve their targets very well. So I'm not going to talk about the rest of the things because it is already being discussed, and especially up to 64 years. I think with the current definition of middle age, you can go up to 60 years. So still many of you are like in the middle age. And anyway, the balance and strength training also recommended. So the high impact exercises for young. So this is the area that we have to think about, like our children. You know, most of the time, because our parents and, you know, grandparents are every time, you know, their first word for their kids is don't do, don't do, don't do. You can see even sometimes you can't, you know, suddenly you can't, you know, change your directions while you are doing. Your grandmother or your baby caretaker will, you know, talk about don't move, you are too fast. I mean, those are things what is happening today. And our younger generation, you know, in our adolescents population, 80% of adolescent populations are being inactive compared to the recommendations what WHO is given. So this is the deep exercises you do, the burpees and the squat jumps. And you can do, like you can see, it's not easy to perform. And some of the advanced exercises, the high impact. So this is the kettle. So we have the kettlebells even in my units. So it's very high impact exercises. You can do without any problem. It says it has own rhythm. And the jumping jacks, right? You can go up to about 10-15 seconds, but that's more than enough. You don't need to go about the hours of exercises. So in your effective exercises routine for osteoporosis, definitely the joint reaction forces superior to the common daily activities with sensitive muscle strengthening program. And it should not be a site specific one. You must do a multi-component exercises. So you have to perform at least 4 to 6 months for the effective results. So there are so many other concerns when you are talking about these exercises, like frequency of training and impact exercises, especially the resistance exercises, weight bearing, flexibility, and all these things, how the big picture is coming into play when you're managing osteoporosis with exercises. So this is the exercise guideline to improve the osteoporosis and prevention of falls for individuals with osteoporosis. And finally, so when it's come to this conclusion, and you have this, the big picture around us, that is the patients with osteoporosis or osteopenia, and the methods. But we are going to, talk about this. It's a evolving phase, as correctly said by Dr. Charles Antonypillai. There are a lot to be explored, and a lot new things are being coming up. Systemic reviews and RTI studies, and resistance, impact, balance, aerobic, and there are new form of exercises which we've been introducing every day. So we are also follow all these protocols and how to incorporate into our system. Especially that we are thinking about the outcome measures, improving osteoporosis, and also the fall prevention. So you can see the resistance exercises are free weights, machines use exercises, intensity 50 to 85 1 RM. That is, at least you have to think about your exercises level. So usually we don't measure this 1 RM, but we start with a low level of weights and then gradually increase 10% per 2 weeks. Actually 5 to 2 repetitions, that is enough, 2 to 3 days per week. But remember, you have to continue for about 3 to 12 months. So the other impact exercises, again, at least for 6 months. So remember, because you have to encourage these exercises even in younger children and younger generation, and even the middle-aged people. But remember to continue for at least 6 months and we'll get the results. So in my conclusion, so the multi-component exercises mainly comprise the resistance impact exercises, which we highlighted the impact exercises. Those are actually the effective strategies to attenuate these problems, which we're talking about today. And integration exercise programs, guidelines, individualized exercises, because all the patients refer to us, as well as by the geriatric, as well as sometimes the endocrinology, and even some other problems. When we detected this problem, we actually go through their entire problem list, and we have a very tailor-made and guided program. So thank you very much for everyone for this great opportunity. We talk about the rest of the things later at the question forum. So I would like to introduce my next lecturer. Is none other than Dr. Kapila Ranasinghe, who is the orthopedic surgeon in Kandy National Hospital. And we don't need to, give him a big kind of introduction, because well-known person. He's been here for a longer time, and his work has been published in many places, and he's a very dynamic and very enthusiastic orthopedic surgeon with good skills. And over to you, sir.
Good afternoon. Thank you very much, Asela and the KSM, giving this opportunity to address in orthopedic perspective in this osteoporosis day, it's actually 20th. So, how we do exercise in the fracture patient with the osteoporotic bone. So you can't do that fixation of the fracture. So that is where we come into play. So as from the beginning we discuss, osteoporotic is a silent disease, because it's till last moment there's no symptoms or signs. Sometimes the first symptom may be the fracture, so then you can find osteoporotic, or either fracture associated various consequences. So it's like a silent killer. So it's a very high time to discuss further. So osteoporosis generally we manage as a multidisciplinary team involving various specialty, but it varies depending on the stages and the disease condition. If it is a no fracture, so anyone can, any doctors can treat for the osteoporosis, various according to the guidelines. But if it is a fracture, get osteoporotic fracture, the leading role by the orthopedician and the maybe orthogeriatric team to handle this situation. So right. So osteoporosis is a two-stage disease, as Charles explained. So it's a with fracture, without fracture. So we are involving the with fracture. So without fracture, also the another phase we need to be divide. Little bit maybe you are getting boring with the repetition, but still I think it's worthy. Osteoporosis is a systemic disease, as you know already. Reduction bone mass and the quality of the changes like macro and micro architecture and mineral properties and the geometry of the bone and the micro damage. So those are the changes happening sequentially. Potential location generally the spine and the neck of femur, neck of humerus, colles fracture, and also silent fracture of the pelvis, usually PB cremi. So what is insufficient fracture? It's unable to withstand normal stresses. I mean, if you get a fall, you get fracture. But in the normal day-to-day twisting, bending, and sometimes turning, you can get a fracture. Especially the pelvic bone, there are a lot of muscles attached. So these are called insufficient fracture. But fragile fracture already discussed. Fragile fracture is a fall from the standing height. The osteoporosis is another entity. The same umbrella. So fragile fracture is a costly surgery. We'll come to later why. And the hospitalization, rehabilitation, heavy burden to the family, caregivers, and nursing homes. Nowadays, nursing home find the nursing home even difficult to find a proper nursing home. So that's a problem in the country. Enormous impact to the patient quality of life, mobility, and the independence. So you may be experience in your life as well. 80% of fracture patients worldwide neither assess nor treatment for osteoporosis. So you can imagine these are world figures. The 80%, so only the 20% will get proper treatment for the osteoporosis following the fracture. So most of them are neglected by various reasons, financial and some other reasons. So when you come to the proper orthopedic point of view, so we do fracture fixation, some guideline. The core principles generally we follow. So need anatomical reduction. If you get a fracture, we need reduction anatomically. It should be stable fixation and preservation of blood supply. Without blood supply, it won't heal. And we need early mobilization. If you not mobilize early, what will happen? So all the stiff joint is going to be stiff, and the muscle is waste, as Charles Carrick said, is going to be disuse osteoporosis and so many other consequences. So these are the four rules we follow any fracture, but it's going to be changed depending on the age and the various other concerns. So specific consideration, patient assessment, and the patient specific adaptation. So we can't get, if you get a femur fracture, maybe 35-year-old is differently we think, but if it is get a 75, we think differently. So the age is concerned and the comorbidities, various other medical conditions will matter a lot. And the fixation techniques like minimally invasive or modern techniques. There are various techniques coming up. So the most of the time nowadays we try to do minimally invasive technique to preserve the blood loss and also preserve the blood circulation. And it will improve the healing because we don't disturb the fracture hematoma. So that is a basic thing to heal the fracture. So we'll try to do a nailing or various other devices where using the under CR. And also we have to consider secondary prevention. So like how to prevent further fall or either improve the quality of the bone, and if there is a supposing poor vision, they may be fall due to poor vision, and they may be due to various other home condition and hearing problem, polypharmacy and depression, and so many conditions where you have to address and you have to refer and get the sorted in the same setting or either clinic setting. So these are secondary prevention. And the functional goal, when you get a fracture, we face how to get independence and an early functional recovery. So all these are, we are getting challenge. It's going to be change patient, the various fracture pattern and their social and the home condition. But always we are face all these challenge when you get a fracture osteoporotic patient. And also team-based care. Patient overall care is a plus need orthogeriatric co-management, because they various medical problems and also need follow-up. Sometimes the orthopedic team to be follow-up for the further maybe a couple of years may not be possible to start various other drugs, and the fall prevention aspect and also the social aspect and the home environment improvements. So many things come one after the other. If you get a fracture, it's a start of the beginning of the sequence of events. So always need a team care. The fixation issue, when you come to the fixation, so various issues we face, because bones are thin. As Charles correctly said, there's no cortical structure, just a trabecular pattern. So any screws won't hold because there's no bone mass. So we'll put a screw, without no time you can pull out. So these are problems. So the fragility cortex and poor screw purchases and the high risk of screw cut out, and also difficult to obtain rigid fixation. As I said, the AO principle, we need rigid fixation, and patient able to the heal poor because they are the bone quality, calcium, vitamin, and maybe nutritionally they are very poor. So we are facing all these challenges if you get a osteoporotic fracture. So how we are going to overcome? One by one we have discussed a few things. The screw failures, because they are the most commonly we are facing. Standard plate, we put on the plate on the bone like this. We put on the plate or the bone. So in the first the right hand picture, you can left hand picture, you can see the conventional fixation. So the screw is directly fixed with the plate and the bone tightly, but in the lock-in plate and lock-in screws, there is small gap. So the screw head is fixed to the plate and the screw thread is going to the bone. So there is no compression, direct compression to the cortices. So that is a new technique we use, especially osteoporotic fractures. So leads to if you use this the conventional technique, so what will happen? Screw loosening and lock-in screw is the solution. The plate and bone compression is limited, so the lysis is going to be less, and the sustainability and the healing and also rigidity is going to be maintained. So we use purposefully the osteoporotic fractures, the lock-in plate rather than the conventional plate fixation. So we can see. And another point, generally if it's thick cortex, you can purchase one cortices screw, but if it is a osteoporotic, so they recommend the capture both cortices. So it will hold more torsional force and also rigidity is more. So these are few techniques we use to osteoporotic bone to fixation. Fixation failures generally may be a little bit boring for you, but screw cut out, you can get a screw coming up, and also screw pull out. Next slide we'll see. Then varus collapse and the malunion, non-union. So we can see all these pictures here. So this is called varus collapse. You can see that they have fixed, but in the head of the humerus is collapsed down because of there's no control over their head and the shaft. And also a screw cut out, you can see this jutting out from the top. So this is a bad failure, and plate pull out here due to various problems, and also the screw is very bad failure. All these are not my complication. So next, the peri-implant consideration. So before implant, so avoid stress rises. So we'll come the pictures by bypass implant. If you get a 2 implant fixation like this, so stress rises come here. If you like this, because bones are very porotic and thin, this is fixed with the intramedullary device, this is fixed with the plate, and this is the weakest place you can get break. So we have to think about how to deal. So, and the bridging implant is the option, and indirect reduction techniques and the limiters of tissue stripping, all these will matter for the good healing of the osteoporotic bone. But it's same thing you can apply for the normal fracture, but this is special. So poor reduction and the hardware position. So if you not reduce the fracture, the neck of femur is like a bread and butter every day, because yesterday my casualty, I think 6 or 7 neck of femurs. You can imagine the burden, the elderly population getting more, not due to osteoporosis, maybe due to various social reasons, but these are, if you get osteoporosis, as Charles Carrick said, you don't have to wait to start osteoporotic treatment, right? These are well-known 5 things I always tell. The spine, the neck of femur, neck of humerus, colles fracture, and the spine wedges, and also silent fracture of the pelvis. So these are 5 areas until pronounced the osteoporotic fracture in the elderly. So superior screw cutout and varus collapse, you can see here. So poor technique and the poor screw positioning, and it's going to be failure. So what I'm telling, so we have to be very minimum narrow window. You have to get in the first chance to fix the correctly, otherwise there's a ensure these failures. And these are bridging technique, the plate and nail. You can, I told we can't stop plate here, because these are periposterior fracture, the total knee replacement, there's a fracture here, and they have done some the hip fixation. So there is a fracture, maybe twisting injury. But if we can stop plate somewhere here, but it's going to be another fracture here. So you need to be bridged all the way up, and cable and various other technique. So these are the things we do to prevent further fracture. These are nail. If you get a neck of femur, or there's some neck of upper femur fracture, so we need to be cover whole femur, because we know it's from the beginning is the whole bone is pathological. So we can get another fracture if you stop somewhere there, because they are short nail, so easy to put, no time, but you maybe get another fracture in another maybe 1 or 2 years time. And another technique, so osteoporotic augmentation. Augmentation means because already fracture bone is collapsed, there's generation and there's a big void, so you know how to fill up. The one option is bone graft. Sometimes his whole bone is like the eggshell, there's no inside, so we have to put various artificial material, so we can fix here to prevent the raise the collapse here, because these are bone cement, polymethyl methicillate acetate. So we put mix with the 2 component, and it's like a paste, and we fix into the gap, and we'll put the screws and plate just to prevent, and it going to be remain as convenient to the patient. So So another area is osteoporotic vertebral fracture is a very common, and most of the time we neglect, as said previous speakers, and majority of osteoporotic fractures heal without surgery, because surgery play a very little role for the osteoporotic wedges. 15 to 35% the unstable fracture. So unstable fracture classification I'm not going to discuss here. According to the guideline, the more than 40% collapse of this height. So you can say unstable. If it is a two fracture adjacent, is unstable. So persistent pain and the severe collapse and the kyphosis, even sometimes can give us, you can acute kyphos, plus or minus neurological deficit. Sometimes neurological deficit will come later. Some people come with the girdling pain. Some people come with the new neurology coming with the radicular pain. So then these are the indication for MRI scan, because this collapse is going to progress and sometimes going to be retropulsion and the compression of the neural canal. We never know, but most of the fractures will heal without intervention. We need to fill up the whatever the bucket with the calcium, vitamin D, and supplement. But you have to follow up all these patients, because we never know what will happen with the long run. Then it leads to poor activity of daily living if you get a fracture. Subsequent fractures risk is 4%. So if you get a osteoporotic wedges, so need to be treated by medically, and also you have to follow up for a certain period. And particularly they can get a pulmonary complication, and the deformity can progress, and spinal deformity mainly sometimes going to be kyphus, and the scoliosis is like a degenerative scoliosis, and so many cosmetic issues. And the management wise, as I said earlier, is mainly conservative. Pain management is the key, because all these patients come to you because of pain. So we have to respect for the pain. We have to address the pain. So that is a basic concept. If pain, they won't come. Even any unstable fracture, they can find some other solution. So pain management is key. So it's again difficult, as he said, that you can do various combination of pain management, and sometimes teriparatide for the osteoporotic wedges, and some nasal sprays. So many things according to your knowledge and experience, and the brace to various level, and the height is depend on the fracture site. And the physiotherapy, once you get come out from the acute pain, strengthening, core strengthening, back strengthening, and the physiotherapy protocol, and we need to refer to the physiotherapist. First, we need to be the local therapy, heat, ultrasound, and various therapy, just to ease out that area pain, and also strengthening exercises. And also then you have to advise them to go for the lifestyle modification exercises, as correctly said the Asela. So these are long-term follow-up. I mean, you can do in a one piece of the session. The surgical treatment is option, and especially unstable fractures are, as I said, very severe collapse, and also multiple collapse, and acute gibbous, and various the hypers where you can't see far away. They are like a squash, like, so you can't see only the few meters. Then they can't walk. Then you need to fix and get the correct posture, and all these are few indications. So surgical strategies for the spinal fixation. The screw wise should be larger diameter screws, because the purchasing power is more, and the length is long screws, and the conical screws, and the cortical screws. So they should be bicortical. So these are the screw the properties for the especially osteoporotic fractures. Fixation techniques like under tapping. Usually our technique always we drill, tap, screw. So tap, drill, tap, screw. But this is where we drill. Sometimes we don't tap, just screw, because screw is going to be tapping and get the whole the bone, because their bones catching power is very poor. So we don't tap to improve the core. And the long constructs, sometimes the acute setting we do the one above, one below fixation, but in the osteoporotic we need a long fixation, maybe 3 above and 3 below, because there are some another osteoporotic wedges we need to control, and the bicortical screw, expandable screw is not available. And if it is a cement augment, you can you can pressurize cement into that drill and screw that, so it will good holding power. And also lumbar interbody fusion. So sorry, there's no picture. So usually get a if you see this picture, if you get a wedge fracture, usually these are posterior, this anterior, the wedges come anterior. So we fix here, the posterior fixation is commonly, but if you not address this anterior wedge, sometimes it's going to be progress and screw failure, screw cutout. Some recommend for the cage for this area just to hold the anterior collapse. So these are little bit high level, but I just to understand the concept. So these are called lumbar interbody fusion, and the prophylactic or the therapeutic vertebroplasty. These vertebroplasty or the kyphoplasty. So there are some criteria to fulfill. There should be a end plate should be intact, and the patient the medically should be fit enough to, and no allergies to bone cement, and they pass to the pedicle. There's some balloon pass to the pedicle and inflate the balloon, and they expand the bone to certain level, and they pass the bone cement and keep it like a augmentation. So this is very useful in the pain management, and also keep the body posture. So these are some people doing the day surgery procedure. Some are it's going to be only concern is bit expensive, but still worthy. Right. So the hip fracture. This is very important understanding, and also maybe a couple of things are going to repeat. 6 to 10% of 30 days mortality. If you get a hip fracture, then we don't have national guideline, but when you go to the other countries, we need to fix within 72 hours. So that is the other country national guideline, because to prevent a complication. As I said, if you keep in the bed, the health cost is more. Bed sore, the urinary tract infection and chest infection and the delirium and chest DVT, pulmonary embolism, whatever the under the sun you can get. So always you have to fix earlier the better. But still 30 days mortality, you can imagine up to 10%. We fix and discharge, sometimes they're going to die at home or some medical ward. So that is the reality. So 27% mortality within 1 year. So even 27% the high fracture mortality, even fixed. These are what I'm saying, the after fixing in the ideal time. 50% unable to walk independently, and 50% will not come into formal mobility level, and 60% assistant with activity of daily living after 1 year. So depression, chronic pain, so many other conditions follows. So summary, understand the poor bone quality in osteoporotic fracture patient, and adjust implant choice, the fixation strategies accordingly. So these are the various techniques that we adhere to the AO principles. Implant design address some of the challenges. They still need understand fracture biology and the augment bone, where to do that, improve fixation technique. So it's a tailor-made individual basis, and also various other things. Osteoporosis is significant undertreat even after fragility fractures. Thank you.
And I would like to thank the KSM for giving me this opportunity to speak in this symposium. So I will be talking about falls management in older adults. So first and foremost, I have to tell that falls is a geriatric syndrome. It's very important in geriatrics. It's a frailty syndrome. And also, Dr. Antonypillai initially introduced the FRAC score, and with regard to osteoporosis management, so the falls prevention is one of the core important principles. And now there's a revised FRAX tool that is coming as FRAX Plus. And in FRAX Plus, they have indicated the number of falls in the last 1 year. So that is important in managing osteoporosis, because however the much that we give treatment, there's no point unless we cannot prevent falls. So that's why it's also included in the newest version of FRAX, which is the FRAX Plus tool. So a fall is not a diagnosis, it's a symptom. So elderly patients present with a fall, but there would be an underlying hidden problem with the fall. So you have to dig into that. And about 1 in 3 adults who are more than 65 years fall annually. So it's about 33%. And there are a multitude of negative consequences associated with falls. So as we discussed earlier, injuries, which could be fractures and also head injury and then intracranial bleeding, then increased mortality, then loss of independence, ultimately leading into poor quality of life, and then also the economical burden. So in my presentation, I would be discussing multifactorial risk assessment, key points in history and examination, what we should look into, and multidisciplinary interventions. So what is a fall? So it is an unexpected event in which an individual comes to rest on the ground, floor, or lower level. And we say it is recurrent falls if there are 2 or more falls within the previous 12 months. So with regard to the statement, a 73-year-old man presented with an accidental fall. What do you think about this statement? So often in trauma wards, orthopedic wards, and also in accident service or emergency departments, wards or surgical wards, when patient presents, when an older person comes with a fall, we document or we describe it as an accidental fall, but the terminology is incorrect. So accident is an unexpected or unpreventable event, but if you really look into the history, for instance, if this man presents after a falling because of a tripping over a stone, so you have to think, if I face a similar circumstance, would I fall? So I would not, because the first thing is my vision is good, so that I will see the stone, that there's a stone there, and I will try to prevent tripping over that, because I would be able to see it, so that I would be able to avoid that stone. Then also, even if I trip over that, I have good corrective reflexes, but I have good righting reflexes, so that I would be able to prevent the fall. But it's not the situation in older adults, so that's why they fall. So always there are multifactorial reasons for them to have a fall. So it's our role is to dig into the history and examination and identify the risk factors of falls. So those are not accidental, those are not mechanical falls. So the terminology is incorrect. So there are a whole lot of reasons for falls. So there are intrinsic risk factors, extrinsic risk factors. If you look at sensory, it could be because of visual impairment, could be due to cataract, or could be due to diabetic-related retinopathy. And then they may also have a hearing impairment, and also possibly having vestibular problems, and then also peripheral neuropathy with absent proprioception. It may be because of neurological causes such as neuropathy, either due to lumbar radiculopathy or peripheral neuropathy, then the Parkinson's disease, stroke, dementia, cerebral disorders, then sarcopenia. So we talked about osteoporosis, which is a disorder of bone, and sarcopenia is a disorder of muscle. So in sarcopenia, there would be reduced muscle strength, muscle quantity, and ultimately the physical function will be affected. And then, of course, frailty. And then musculoskeletal problems such as knee osteoarthritis, chronic back pain, any chronic pain syndromes could lead to falls. Then cardiovascular causes such as orthostatic hypotension, cardiac syncope, and other arrhythmias. Then delirium, incontinence. For instance, it could be urge incontinence. So if an elderly female is having urge incontinence, they would rush to the toilet. So while they are rushing to the toilet, they can fall. And also because of the leakage of urine to the ground, then again they can slip over that urine and fall. Then depression, anxiety, and also after a fall, they could develop fear of falling. And that itself is a risk factor for another fall. These are few intensive risk factors. And there are multitude of environmental hazards. So the loose rugs, the carpets, then the poor lighting, and other furniture cluttering are some of the risk factors. Then poor footwear. So recently we had a lecture on footwear by one of our orthopedic surgeons. So they, I think, have understood that the importance of proper footwear. And also using assistive devices, whichever the walking aid that they use, it itself is a risk factor for falls. And then iatrogenic, of course, the polypharmacy, the medications that we are giving. So if a patient presents to the A&E following a fall, so as the A&E protocol, we assess the ABCDE, and then also we try to look at the injuries. We have to identify the injuries. It could be scalp injury, it could be head injury and then intracranial bleeding. There could be problems in the cervical spine, so look for cervical spine tenderness. The patient may be having rib fracture, so look for chest wall tenderness. Then they may be having problems in their spine or also in the hip fracture, so look for hip stability as well. And also it's important to screen for underlying acute illness. Now, if a patient just presents with a fall, so that could be the initial presentation of an underlying infection. Because we know that in elderly, that they would not, now if a patient is having an infection, they would not mount the typical clinical features of an infection, such as fever, they would not have dysuria, they would not have cough. They may develop delirium because of the infection and then ultimately would have a fall. So fall is the initial presentation. So that's why at the beginning of the presentation I mentioned it's a symptom. So we have to look for the underlying diagnosis. So the fall could be a presentation of an underlying infection, maybe pneumonia, maybe urinary tract infection. Also, it may be the presentation of a stroke or a seizure or maybe a cardiac syncope. So you cannot just simply fix the fracture or to admit to a surgical ward, but at the same time, you have to look for the underlying acute medical problems as well. And when you are taking a fall's history, so the important thing is now in the current fall, so the history and examination would give you more clues to what exactly has happened. So when you are evaluating the current fall, so you have to look into three components. One is the pre-fall, then the fall, and the post-fall. So in the pre-fall, we should know what is the location of the fall. Where did this happen? Whether it's in the indoor, if it's indoor, whether it's the bathroom or the bedroom, or whether it is outdoor. So what is the location and what is the time? Whether it's a nighttime fall or the daytime fall. And what was the patient's circumstance? What was the patient doing when this fall happened? Whether the patient was standing or whether he or she just got up from the chair. That could be related to postural dizziness. So what was the patient doing and what was the patient could recall? And then whether it was a routine day or whether the patient had their breakfast, this may be related to hypoglycemia, or whether they had any vomiting or diarrhea before the fall or in this event. So likewise, you have to analyze the pre-fall events. And sometimes you would not be able to get the proper account from the patient because they may be having delirium or maybe having dementia. So they would not be able to give you the account of the fall. In that situation, you have to get a collateral history. Sometimes there would not be an eyewitness as well. In that case, we would be in trouble because we would not be able to get the proper history. So then we have to think about possible causes and evaluate on that line. Then the fall. So sometimes now the loss of consciousness is an important thing that we have to ask in the history, but it's very important to identify whether the loss of consciousness happened before the fall or after the fall. Because if it happens before the fall, it may be related to syncope or it may be related to seizure. And after the fall, it could be because of the post-concussion effects. So because of the head injury. So to ask whether the patient could recall the hitting on the ground or the floor. If they could recall how they hit on the ground, that means if the loss of consciousness has happened, and if they could recall hitting on the ground, that means loss of consciousness has happened after the fall. But if they cannot recall, so that's why you have to dig and ask, what can you last remember? What can you last remember? Because when you get the history, you may have experience. They want to highlight facts that happened afterwards, how the neighbors came, how they were brought to the hospital, and those things they want to highlight. So you have to try to identify the important key points in history. So whether the loss of consciousness happened before or after the fall, if there's a history of loss of consciousness. So how then the fall and then the post-fall events. So in the post-fall, again, what are the injuries, whether they had any pain or whether they had head injury, and then the loss of consciousness after the fall. And also whether the patient was able to get up by themselves. So because in elderly, after a fall, sometimes they would be able to get up by themselves, sometimes they would not be. And if there's long lie, if they could not get up by themselves, whether they lie on the floor for more than 1 hour. So if there's long lie, there could be a risk of rhabdomyolysis as well. So sometimes, especially if a patient is living alone by themselves, after a fall, they would not be able to get up by themselves. So the neighbor or one of the relatives who will be visiting after 1 or 2 days ultimately would be able to identify that the patient is just lying on the ground. And at that point, there would be rhabdomyolysis and also there would be pressure ulcer development. So whether there was a long lie also important. So that is the analysis of the current fall. Then the past falls. So it's here in the past falls, at least try to identify any falls within the last 1 year. Again, the recollection or the recall would be problematic in elderly because they may be also having underlying cognitive impairment. Therefore, you need to get a collateral history. So if there are recurrent falls, again, try to identify the frequency timings. If there are more nighttime falls, that means there could be a problem in their vision. And the location. Sometimes those falls happen in the bathroom, always in the bathroom. So that means there's a problem in the bathroom. So you have to address that problem. So what is the location? So you would be able to identify a pattern by analyzing these falls. And then, of course, the circumstances. And whether they had any injuries in the past. So in examination, so we look at vision and hearing. So vision, simple test like the Snellen chart, or else if you ask from the patient whether you could see properly, then they would answer. Then the hearing, look for cardiac murmurs, especially cardiac aortic stenosis, because in severe aortic stenosis, there could be reduction of cardiac output leading into cardiac syncope. Pulse, look for arrhythmias, bradyarrhythmias. Then the postural hypotension. So when you're looking at postural hypotension, you look at the blood pressure in the supine position, then ask the patient to stand up and check blood pressure after 1 minute, and then again in 3 minutes, and if possible after 5 minutes. Because in postural hypotension, there's something called initial orthostatic hypotension, classical orthostatic hypotension, and delayed orthostatic hypotension. Then the muscle power, they may be having proximal myopathy, maybe also having sarcopenia. So chair eyes test is an important determinant of, it's a proxy to detect sarcopenia. Then the balance, gait speed, and the timed up and go test. Features of Parkinsonism. So simple test you can assess for bradykinesia and rigidity and also look for any rest tremor. Then the coordination, look for cerebellar features. Then the sensory examination, including the joint position sense and the cognition. So because initially I discussed what are the intrinsic risk factors for osteoporosis. So at least in your examination, try to see whether the patient is having any of these problems. Now, this is the 4-stage balance test. So this is what we usually do ECD. So you ask the patient to stand with their feet side by side, then place the instep of 1 foot. So it is touching the big other foot, and then the tandem stand, and then the 1 leg stand. So ask to stay in one of each position for 10 seconds and see whether they can hold. And there are other specific balance tests like Berg balance scale, then there's Tinetti balance scale. So those are where they are looking at dual tasks, when someone is doing dual task and whether they can manage steps or not. So those are advanced balance tests, but at least this is a 4-stage balance test. It's easy to perform. And this is the timed up and go test. This is a very important one in geriatrics, and because it is not only for falls, you can identify many things. So here what we do is we ask the patient to sit in a armed chair with their usual footwear, and then if they are using a walking aid, they can use that as well. Then when the time starts, you ask them to sit, you ask them to stand, and then walk 3 meters, then turn, and then walk back, and then sit. So there you could appreciate whether the patient can stand without holding to any support, and what is their gait, whether it is unsteady, whether there's evidence of proximal myopathy like waddling gait, whether there's evidence of Parkinson's, shuffling in gait, and then the turning. So you could see the balance during the turning, and if it's Parkinson's, you could see turning en bloc, then walking, and then how they stand, how they sit. So there are different cutoffs of timed up and go test. So falls, it's taken as 15 seconds. If more than 15 seconds is taken to complete the timed up and go test, it would indicate that there's a high risk of falls. But it's always clinical judgment, so don't just go by the numbers, but look at the clinical picture, how the patient is behaving, and then decide. Then this is the chair stand test, which is a proxy for sarcopenia. So here you ask the patient to keep their arms like in this position, and then do chair standing 5 times and check the time. So if the chair stand is again for more than 15 seconds, then it is positive for high falls risk. But again, there are caveats. For instance, if the patient is having knee joint osteoarthritis or proximal myopathy, then obviously the chair rise test will be prolonged. Then to assess cognition, there are simple tests. One of them is the clock drawing test. Here, the standard time that we are asked to allocate is 10 minutes past 11. Because in the clock drawing test, we look at how the patient is having visuospatial function. So what the command is, we ask the patient to draw a clock and then put their numbers and then mark the time 10 minutes past 11. So one thing is we are looking at the visuospatial, how they put numbers, and then also there's actioning of the executive functions, because if I tell 10 minutes past 11, then the patient has to mark number 2 and number 11. Sometimes patients would just mark 10 and 11, because that's why the time is, it's given as 10 minutes past 11. So in Alzheimer's, you could see that the visuospatial function is affected, and also the executive functions are affected. In Parkinson's, it would be again very small drawing. So this is clock drawing test. This is an important tool for any geriatric patient that you could use. And then basic investigations, so ECG to look for any cardiac arrhythmias, then the full body count electrolytes, then TSH, thyroid functions, vitamin D, glucose, whether there's hypoglycemia, and if there's long lie, do creatinine kinase, because I mentioned that there could be associated rhabdomyolysis as well. So depending on the history and depending on the injuries that you suspect, you could do the imaging. And other tests, such as if you are suspecting cardiac syncope, then Holter test. If you are suspecting seizure, then CT imaging and also EEG. Other tests according to the clinical scenario. So management of falls, again, it's a comprehensive geriatric assessment where we are looking at the physical components, socio-economic environmental problems, their functional situation, mobility and balance, psychological and mental problems, and the medication review. So it is done by a multidisciplinary team with the doctor, physiotherapist, occupational therapist, pharmacist, social worker, and the nurse. So let me go through a small case. So this is a 78-year-old man who presented with recurrent falls. And he has a history of cervical dystonia, torticollis, and ischemic heart disease in 2021, who had a coronary stent placed, and also having gastritis, osteoporosis, and type 2 diabetes. On examination, he's having evidence of Parkinsonism and cognitive impairment, and blood pressure is 100/60 with postural hypotension, and his HbA1c is 6.3%. So he's a complicated patient with multimorbidity. coming with postural hypertension, HbA1c of 6.3 with evidence of Parkinsonism and cognitive impairment. And this is his medication chart. And these two as well. So calcium and vitamin D, of course, for secondary prevention of osteoporosis. And you could see, so it's 18 medications he's taking. So now in elderly, it's very important that you do a medication review at every instant that you come across. Because what happens is there's multimorbidity. So patient goes to different specialties like cardiology, endocrinology, nephrology, urology, and each specialty prescribe medications according to their guidelines, according to the problem. But this is a patient with multiple other medical problems, who is also on other medications. So every time, look at the drug chart, look at the medications that they are taking and see whether they are necessary or not. Now, this patient is having cervical dystonia, so that's why he's on baclofen and clonazepam. So those are muscle relaxants. But baclofen has anticholinergic properties. Clonazepam is a long-acting benzodiazepine, so it can also cause sedation and drowsiness, and it can cause falls. Sertraline was started some time ago, initially for low mood. But this also has anticholinergic properties, and now it's continuing repeatedly, now about for more than 2 years. And he's also on dual antiplatelets. But mind you that ischemic heart is the acute coronary event happened in 2021. And you could appreciate that in a patient with recurrent falls and also on dual antiplatelets, and if they develop a head injury, what could happen? Then some time ago, there was a diagnosis of BPPV, benign positional vertigo, and then started on prochlorperazine. So prochlorperazine is a first generation antipsychotic. So this, now the patient, I told you that the patient is also having Parkinsonism. It's a symmetrical Parkinsonism. So he is having now drug-induced Parkinsonism because of prochlorperazine, which was again continued indefinitely for over the years. Then also on vitamin B complex. And he's also on furosemide 20 mane. So he does not have clinical features of heart failure. So probably with the initial acute coronary event, there may be evidence of heart failure. Then someone started furosemide, and that's also continuing indefinitely now. And losartan. So this has mortality benefit in acute coronary event, but for ischemic heart disease. But now the patient is having postural hypotension. So also 2 antihypertensives, losartan, amlodipine, and also 3 bisoprolol as well. There is HbA1c 6.3. He's also on glycoside 40B. So it's a sulfonylurea. And remember, in elderly, so there's something called Beer's criteria, which is the BGS, it's the American Geriatric Society's Beer's criteria for inappropriate medications. And sulfonylurea is one of the inappropriate medications for elderly, because there's a high risk of hypoglycemia. So if this patient with HbA1c of 6.3 developed an acute illness and then start not to eat, start vomiting or diarrhea, then in that context, if we give glycoside, the patient could develop hypoglycemia. Then GTN, ISMN, so this is for the ischemic heart disease. So remember now, for a young patient, now ISMN is a nitrates and it's an anti-angina. So for a young patient, when they are walking, when they are exerting, when they are climbing stairs, they could develop anginal symptoms. But in this 78-year-old patient, now his gait, if the gait is very slow, so they are not mobile as when they were young. So, usually they would be like, if they are like homebound, then we know that they would not exert much. So then there's no such demand-supply mismatch like in a young patient. So when their exertion level goes down, try to de-prescribe nitrates as well. Because again, nitrates can cause, those are vasodilators, it can again reduce the blood pressure. So then it can cause falls. And then of course, beta-histidine again started for BPPV, and now it's continuing indefinitely. So if you look at this drug chart, there are a lot of inappropriate medications and which could lead to falls. So medication review is one of the very important things in any elderly patient, whether they are coming with falls or not. So look at all the medications that they are taking from different specialties, because sometimes there could be duplication. So recently I had a patient where a parent team referred this patient to another specialty to review the baclofen whether to see whether they could reduce the dose. So the patient was seen in the private sector, and baclofen initially was on 10 milligram, and the consultant reduced it to 5 milligram. So from the private sector, patient bought 5 milligram of baclofen, and then at the hospital, the parent team did not notice that, but they prescribed 10 milligram of baclofen again. So patient didn't know that he was taking the same thing. So now the patient was taking altogether 15 milligram of baclofen, even though intended to take 5 milligram of baclofen. So with the multimorbidity, a lot of duplications occur of medications, especially when given at different specialties. And also there would be a lot of drug and drug disease interactions, because if a patient goes to one specialty, they would think about that particular problem and they would prescribe medications. So if you consider that single problem, that management is 100% correct. But mind you, that patient is also having other medical problems and also other medication, the drug disease interactions, drug interactions happen. So what we did was we discussed with the neurology team and gave a botulinum toxin, and then we that is for cervical dystonia, and then we started to tail off baclofen and conazepam. So the other thing is, when you are doing deprescribing, some medications we can't stop abruptly because then they can develop withdrawal features. So benzodiazepine is one such medication. So we have to do it very gradually. Then sertraline, again we discontinued because now the patient does not features of depression. Then we stopped one antiplatelet. We stopped prochlorperazine and beta-histidine. We stopped all these furosemide, losartan, and amlodipine. And then bisoprolol we continued because again we cannot stop beta blockers abruptly. Glucoside we stopped because HbA1c 6.3, IS7 we reduced. So in geriatrics, it's not black and white always. So sometimes it's very gray. There are no specific guidelines that use common sense, that use your clinical experience, and it needs shared decision making with the patient. Because we have to explain the risks and benefits to the patient and take the patient's idea, values, and preferences about continuation of medications. So this is the anticholinergic burden calculator. So if you need to see the burden of anticholinergic properties of your medications, then you can use. So you can see that the sertraline is having anticholinergic property of 2, prochlorperazine is having 2. So these are few anticholinergic medications. So you know that with anticholinergic properties, they can develop irritation, dry mouth, blurring of vision, then ultimately leading into falls and delirium as well. So consider deprescribing. So you could use these criteria, stop-start criteria by BGS, by British Geriatric Society, BS criteria, then stop-frame, stop-fall tool, then there's a Scottish polypharmacy guidance, and then there's also a CDC study initiative as well. So use these tools to deprescribe medications. Because often in elderly, these happens, falls and other delirium and those things happen because of our own medications. So we need to implement multi-domain interventions. So Dr. Ratnayake initially discussed multi-component exercises, strength, aerobic balance, gait, flexible training, and then also there are exercise programs like Otago and Tai Chi. Then medication review is an important part in falls prevention and management. Then correct sensory deficits. Then nutrition and bone health. So to address sarcopenia, there should be adequate protein requirement with resistance exercises, and for bone health, vitamin D and calcium. Then the psychological management, especially if the patient is having fear of fall, anxiety, then we need to increase their motivation. We have to address that as well. Then there's a role, very important role for physiotherapy and occupational therapy. So these are a few walking aids our patients are using. So if you look at this, the first walking aid, you could see that. So if you look at this one, you could see the first one, the base is not that stable. And this is another walking aid where a patient is using the broomstick. And the last one is taken from a tree. So sometimes, like once I saw a patient was using the Gliricidia, the Vatamara, that trunk is used as a walking aid. So you can see our patients, like how unstable these walking aids are. The base is not stable, they can easily break, and then this itself can result in a fall. So walking aids should be prescribed and they should be assessed by a healthcare professional. So physiotherapist, they have to look at the patient's gait, their balance, their strength, and also prescribe appropriate walking aids. So this is a cord stick. So this has 4 steps so that this is more stable base. And this is a simmer frame, this is a rollator, and this is a gutter walking frame. So this is used if the patient is having problems in, like for instance, in rheumatoid arthritis, if they have problems in their hands, then of course the gutter walking frame is used. And if you look at this picture, you would be able to identify a few environmental problems. Their home hazards. So you can see the lighting would not be appropriate. There's a lot of cluttering. The carpet is loose. So this lady can fall easily because of this loose edge. Then there's water is spilled over. There's a dog. And sometimes patients would trip over their pets as well. And then cluttering and then the walking aids. So there's multitude of risk factors in this picture which can result in falls. In addition to that, there could be codes, telephone codes, and inappropriate footwear, then also the clothing. Sometimes like sari, the long skirts, dresses, that could be the culprit for falls as well. So the occupational therapist is also playing an important role where they have to do home visits and see what are the problems at home setup. That's why we need to identify the circumstances, the location of falls, and then need to do environmental modifications. So the grab bars, here you can see grab bars, the commode, and then the shower area, and then handrails. So these are few environmental modifications that should be done. So this is one of the algorithms by the World Falls Prevention Guideline about screening. And this is the STEADY algorithm. So finally, my take-home messages are: fall is a multifactorial geriatric syndrome. Always look beyond the board, find the reversible factors. Many falls can be prevented. Multidisciplinary personalized intervention is most effective. So let me finish by Professor Bernard Isaac's quote. It takes a child 1 year to acquire independent movement and 10 years to acquire independent mobility. An old person can lose both in a day because of a fall. So as healthcare professionals, it's our duty to prevent falls in older adults. So screen. When you get an older patient, try to screen whether they're having falls. Sometimes they would not come up with falls. So you have to probe and ask whether they had any falls in the past 1 year. And these are references. So you can refer the World Guidelines for Falls Prevention and Management. And this is the CDC, the STEADY protocol for older adult fall prevention. Thank you.